Hello, everyone. Welcome. Let's walk through a nursing case. Picture this: you work in a medical surgical unit, you've just gotten a report, you're entering and you're expecting a routine shift, or so you thought. One of your patients is Miss Lamoy. She is a 68-year-old female. She was admitted to the medical unit with a large left sided pleural effusion. Her past medical history includes COPD, hypertension, type 2 diabetes. She's also a former smoker. She had a left sided chest tube inserted earlier yesterday for drainage of a pleural effusion. The chest tube is connected to a water seal drainage system with a wall suction. You've got a report from the outgoing nurse that this patient had a chest tube inserted yesterday. The initial drainage was 600 ml serous fluid, draining minimal amounts overnight. She's on 4 liters oxygen via nasal cannula. Her pain's controlled with morphine. She's been stable overnight. Her last set of vitals were done at 6, and they are as follows: blood pressure 138/76, heart rate 88 beats per minute, respiratory rate is 20 breaths per minute. Her temperature is 37 and her SpO2 is 94% on 4 liters nasal cannula. On your initial assessment, you enter the room and notice that her chest tubing is kinked under the bed rail. She looks mildly anxious and complains of chest discomfort with deep breathing, 5 out of 10. On auscultation, you find breath sounds diminished on the left, clear on the right. Chest movement slightly reduced on the left side. The first question: which nursing action is most appropriate when you notice the kinked tubing? A. Unkink and ensure the tubing is unobstructed. B. Notify the provider immediately. C. Clamp the chest tube. Or D. Remove suction. If you guessed A, that would be the correct answer. You unkink the tubing and ensure it is hanging straight. Chest tubes must remain patent to allow air and fluid to escape the pleural space. A kinked tube traps air, increasing intrathoracic pressure and risks lung collapse or even a tension pneumothorax. The nurse's first responsibility is to remove the mechanical obstruction before escalating and notifying the provider. And you would need an order to clamp the chest tube and removing the suction, both of which would not be indicated at this time. At 9, Miss Lamoy reports increasing shortness of breath, chest pain with inspiration. It's now 7 out of 10, and she's feeling quite lightheaded. Her SpO2 is 82% and 4 liters nasal cannula. Blood pressure 158/72. Heart rate is 105 beats per minute. Respiratory rate is 28 breaths per minute. Lips and fingertips are cyanotic. Her extremities are cool. The left lung on auscultation has absent breath sounds. Her right lung is clear. Chest movement markedly decreased on the left. Which assessment finding require immediate follow-up? Select all that apply. SpO2 of 82%, respiratory rate 28 breaths per minute. C. Cyanosis of lips and fingertips. D. Pain with inspiration. E. Blood pressure 158/72. The correct answers were A, B, C, and D. These findings show impaired oxygenation and respiratory distress. Cyanosis means oxygen delivery is already failing. Increasing pain with inspiration suggests worsening pleural or lung involvement, and early recognition will prevent rapid decompensation. And we want to make sure we're notifying the most responsible provider and respiratory therapist or rapid response team at our unit or site. At 10, Miss Lamoy's current condition is that she's having labored breathing, increasing agitation. She's now tunded, her neck veins visibly distended, her arms are swollen, her trachea appears shifted to the right, and she has muffled heart sounds. Her vital signs are as follows: blood pressure 92/50, heart rate is 135 beats per minute, respiratory rate is 12 breaths per minute and shallow, temperature 36.9, SpO2 81% on 4 liters nasal cannula, and her pain is 10 out of 10 with breathing. pH of 7.19, PaO2 55, PaCO2 75, SaO2 80%, HCO3 or bicarb is 28. Based on these findings, which complication is most likely occurring? A. Pulmonary embolism. B. Fluid overload. C. Tension pneumothorax. Or D. Pneumonia. The correct answer is C. She's having a tension pneumothorax. The distended neck veins, hypotension, tracheal deviation, muffled heart sounds, and hypoxia together indicate rising intrathoracic pressure compressing the heart and great veins. This is a life-threatening situation and it requires immediate attention and escalation. Which order should the nurse anticipate first? A. Administer morphine. B. Assist with emergency needle decompression. C. Insert a Foley catheter. D. Draw blood cultures. E. Transfuse blood. The correct answer is B. Assist with emergency needle decompression. It might also be a finger decompression. Tension pneumothorax is not treated with pain meds, labs, or routine care first. Air must be released immediately or cardiac arrest can occur. This is a true emergency. Emergent decompression by finger or needle thoracostomy is required to prevent respiratory and cardiac collapse. Emergency decompression was performed and the chest tube function was restored. The current assessment is the chest tube is connected as it should be. The water seal chamber shows gentle fluctuation. The drainage is about 30 ml light red blood. Breath sounds diminished on the left, crackles on the right, and now she's having symmetrical chest movement and expansion. Vital signs are as follows: SpO2 94% on 4 liters nasal cannula. Blood pressure is 128/74. Heart rate 92 beats per minute, and her respiratory rate is 20 breaths per minute. Which nursing actions are indicated? Select all that apply. Keep drainage system below chest level. B. Ambulate patient in the hallway immediately. C. Monitor water seal chamber. C. Monitor water seal fluctuations. D. Document drainage amount every shift. E. Change chest tube dressing every shift. F. Obtain chest x-ray as ordered. The correct answers were A, C, D, and F. Keeping the chest tube below chest level prevents backflow into the pleural space. The water seal fluctuations tells us the system is working. D. Drainage trends will show bleeding or even complications, and then a chest x-ray will confirm lung expansion. Ambulating too soon risk destabilization. Dressing changes, when not indicated, can introduce air unless soiled or loose. It's 1400, it's the end of your shift. You're writing your report now, and the outcome is that her pain is significantly reduced. It's 3 out of 10. Her SpO2 is 96% on 2 liters nasal cannula. Breath sounds are improving, chest movement symmetrical, no jugular distension anymore, and her vital signs are stable. Nursing assessment save lives. Small details change outcomes. Follow for more nursing case studies. Thank you for watching. Like, comment, share. Also, comment on topics you'd like us to discuss, and I'll see you in the next video.